Welcome to our program, Team Nursing Revisited during COVID-19. The COVID-19 pandemic has proved very challenging for nursing leaders across the globe. Many leaders have had to plan for surge staffing in their intensive care units well beyond, sometimes double, triple, and even quadruple their current capacity. Now, on a recent webinar done by the American Organization of Nurse Leaders, one of the nursing participants from New York who was talking about the way they were managing COVID-19 mentioned that they had moved to a team nursing delivery system during the crisis in order to be able to use some of their deployed nurses from other areas in a much more efficient manner. And what I noticed after she made this comment was that there were a lot of comments in the chat box asking for resources about team nursing. And as I looked at the questions about team nursing, I began to realize that a lot of our younger nurses had probably never worked in a setting that utilized team nursing as a delivery approach. I also did a quick Google search, and I found that really very little had been written in the last couple of decades about team nursing. So I decided to put this video together for two reasons. One is as a resource for those of you that are out there that might want to learn more and may even want to think about implementing it in your settings during this time. And my second reason is that I am knowledgeable about this delivery system. It was really the focus of my doctoral dissertation almost 3 decades ago, and have worked with team nursing as an executive leader in the Department of Veterans Affairs for 25 years. So it is my hope that this program will be of value to you. Now, I think everyone recognizes that team nursing really does require a change in perception on the part of nursing from an I to a we perspective when talking about a group of patients. Now, after decades of primary care nursing as the primary approach that's been used in a lot of health systems, changing a mindset can be very challenging, and thinking about caring for a patient as a team instead of as an individual nurse. So what I'd like to do here is to use an example of a hospital that has been asked to expand their ICU capacity. Let's say their current capacity is 24 beds, and they have been asked to expand their ICU capacity to 48. Now, during a time of crisis, travel nursing, additional travel nurses might not be an option, but leaders in these situations are currently able to deploy team members from other areas, such as nurses from the OR, from PEDS, from behavioral health, from ambulatory settings. And other team members that could also be available include nurse anesthetists, physical therapists, respiratory therapists, even food and nutrition service. Now, when designing team nursing, you can see on this slide that ideally what you would want to do, because these are critically ill patients, is your team leader should be a critical care nurse assigned for overall accountability of the patients. Now, what the difference is the number of patients that critical care nurse might be assigned to based upon team members that are working with her. Now, in terms of that critical care nurse's team leader responsibility, it would include assessment and documentation for the patient. It would also include making care assignments, which we'll be talking more about, and utilizing everyone's talents and core competencies. And then it also involves supervising the care given by others. And you can see that the nurses in this situation could come from many different places, could also include health techs from multiple settings, respiratory therapy, nurse anesthetists, physical therapy. So, this is where you would start to try to look at how to redesign the care that you're doing. So part of what you're going to look at is not only the staff competencies from all of these areas that you're drawing from, but also looking at the care functions that are required for the patients that are being taken care of. So things that you'll have to think about are medication management. You'll have to think about patient assessment, PPE oversight, ventilator or ECMO management. For ECMO management, you might want to stay with pretty much a primary model. It might not lend itself as well to a team nursing model. Patient repositioning. We know that with COVID-19 patients, putting them in the prone position is something that's really recommended to aerate their lungs. Family contact. This has become a really big challenge in intensive care unit. It's because these patients are not, can't have visitors for the most part. So staff are in a position where they're kind of acting also as intermediary and doing FaceTime calls and trying to keep patients connected. And then you have your normal and usual ADLs. So as you begin to think about the team members that you have available, and then you think about the care functions and look at the competencies of what teams could do. An example might be that if you had a nurse anesthetist that was assigned to your team, that maybe that nurse anesthetist's assignment on that team would be to do the ventilator management for 6 to 8 patients, whatever the assignment was. If you get a nurse from pediatrics, they may not be as comfortable with medication management because they're used to taking care of pediatric patients. But when you think about family contact, a lot of the patients that are in ICU right now, some of them are parents and they've got kids at home, and these pediatric nurses often have, real expertise in working with family and technology expertise in keeping family connected with their kids. So what team nursing really forces you to do is not only look at competencies, but look at skills and special gifts and strengths that each team member brings. Now you can see on this slide, we talk about the consideration with team nursing, some of the things that you really need to think about. Communication is definitely the key to excellent team nursing. It can't happen without excellent communication. And normally when you have team nursing, rather than a nurse-on-nurse shift report, it would be a team-on-team shift report where they'd huddle with one another. A key part of that huddle would be to decide on, very clear assignments for each team members. Another thing to be thinking about is the geographic proximity of the team members to the group of patients that are being taken care of. So, another consideration during COVID-19 is the minimization, whenever possible, of overuse of PPE. So this needs to be taken into consideration too when you're giving assignments. And I'm thinking, if you had a perioperative nurse on your team, that person would probably be an excellent person to really give the team guidance about how to structure assignments to minimize use of PPE, and also do kind of on-spot checks to make sure that everybody is using the equipment properly. Now, the team also needs to talk about communication with family members, because this is important. You don't want a team of 4 or 5 people and everybody's talking with the family member, and the family member may feel like they're getting different stories and that it's very fragmented. So how this is done can be decided by the team. Normally in team nursing, it is usually the team leader that would communicate with the family. But I think the COVID-19 situation presents some interesting new challenges, since family is never there in person for the most part. So as I said, there might be other team members that you might assign to go in there and provide the patient with some FaceTime experiences with their family members. The team should, most of the team rounding during COVID-19, normally in team nursing you do team rounding. Team rounding probably doesn't take place in the room with COVID-19, but there definitely is a need to do at least two team huddles during the shift. You'd want to make sure you do one at the beginning, and then make sure again that you do one at the end. Now, one question that always comes up is documentation. Who documents when you practice team nursing? Well, what normally happens in team nursing is that everybody on the team specifically documents on the type of care that they're giving. So everyone would be in the clinical record. The assessment notes would normally in team nursing be done by the team leader. Or another strategy is that the team leader, depending on how your electronic record is organized, that the team leader could co-sign assessment notes that are done by others. Now, great team nursing really obviously requires great team leaders. And so I think a good place to start when you think about team nursing, if you're thinking about piloting it or just want to see how it goes, a good place to start is with some of your intensive care unit nurses who have taken charge, because they're used to situations where they've been air traffic controllers in the unit, and they probably are managing, helping to manage groups of patients more than just one or two individual patients. The team really takes the assignments from the leader. So the leader needs to be very, in this situation especially, but always the team leader should be have clinically very good skills, be a good critical thinker and problem solver. It should be somebody that really knows the unit and the organization, that knows what the policies are, knows what the procedures are, knows who the people are. But then this last one that's on the screen, this interpersonal skills, I think is extremely important, and something that we sometimes overlook, the interpersonal skills. The team has to feel, especially in this situation where you're deploying nurses from other clinical areas, these team members need to feel very psychologically safe with the team leader. They have to feel like they can ask a lot of questions. And so the team leader has to be somebody that can foster that kind of safety. So that brings us to our last section, where we're going to talk about, how do you put team nursing into practice and some next steps. I think all of us understand that initiating any change in our work environment, it can make us feel very, very uncomfortable. In fact, I think the whole COVID-19 pandemic has made everyone feel very, very uncomfortable, because it's really taken us out of our comfort zones. Initiating team nursing would be a change. So I think that you could reasonably expect that you are going to have some resistance, because this isn't the norm in most healthcare settings today. But having said that, one of the really positive outcomes that we're hearing that's coming out of the COVID-19 pandemic is that it has fostered more teamwork and collaboration, in some cases more than most places, health systems have experienced before. It's really forced people to work together in a way that they haven't worked together before. Now, the questions that are on this slide here are ones that I think you can certainly expect to be asked. Things like, is this really patient-centered? A question that I think team leaders always have is my license in jeopardy when I supervise other team members? How do I know that the staff that are assigned to work on my team have the competencies that they say they do, or that you tell me that they do? And is this going to lead to some fragmentation in care? And how can we keep the lines of communication open? So what's critical is that the organization does develop some just-in-time policies and procedures if you plan on doing this. Nurses always worry if their licenses are in jeopardy. That's a question I get asked a lot, and certainly did when I was in executive leadership. And the answer is no, if they follow policies and practices that you have in place, if they're using really good clinical judgment in their delegation, and that's key, and if they follow up, and that's probably the most important thing, is they're being able to follow up and close the loop on care that is being given. They may also worry that care will be fragmented. And there is a risk of this if communication is not good. But here's the reality. Even in the best functioning health systems today in primary care nursing, Um, there still is fragmentation and there still is missed care. Everything ultimately is in execution. So the nurses that are assuming these team leader roles would probably, if you choose to do it, would need some just-in-time education to not only include some of the topics that we've talked about, but also to talk about clear, direct, and ongoing communication. How do you maintain that with team members? How what kinds of how can you be as direct as you can possibly be so you make sure that those team members are reporting back to you? And they also need to know specifically what each team member is capable of doing and what upskilling has been done. A lot of nursing education departments right now are doing a lot of upskilling of nurses that are being redeployed. But how much practice are they really getting with this upskilling, and how comfortable are they with these skills? I mean, those are things that need to be really discussed. Here are the things that we know about team leading and team nursing from the research. That we do know that nurses in general are not always aware of the scope and competencies that other team members have. So if you're using, as an example, if you're using unlicensed personnel like health techs as part of your staffing mix, it's important to know what those individuals can do. We also know that in general, supervision and delegation can be pretty challenging, which is why we're going to talk a little bit about delegation in just a couple of minutes. That communication is key, but we know not everybody has the same style of communication. And that, conflict is natural. When you put teams together, it's a natural part of teamwork and it needs to be managed. And one of the things about team building is that team building is very complex. And here's a challenge that I see today with team nursing that maybe didn't exist 20 or 30 years ago when we did it. Most of the context of team nursing was within the context of 8-hour shifts when nurses were working 5 days a week. We know that that's no longer the case in most of our settings. So how do we get these teams to work together effectively? Do you want to do shift rotations where the whole team rotates on and off? It's something that you really need to think about, because you don't want every single day of the week and shift that you're bringing together all different team members, and it kind of can seem kind of random to the group. Now, in moving to team nursing, it's really important to talk about the professional scope of practice of each team member. Now, on this slide, you're going to see the definition of professional scope of practice that came from the National Council of State Boards of Nursing. But here's an important caveat to think about as you're redeploying nurses from one area to another. Just because a nurse has something within her scope of practice does not mean that that nurse has the competencies to perform that in every area. So if I have had my background primarily in behavioral health, as an example, and I'm being redeployed to work in a surge ICU setting, my assessment skills and observation skills and planning skills with critical care patients is really not there. Even though it's in my scope, it's not something that I have been used to doing. So here's where the critical thinking about assignments really comes in on the part of the team leader. If you redeploy a nurse from a completely different specialty area, even with skill upscaling, the team leader really needs to consider the requirements of care of each of the patients and who really is the best person to care for that patient. As I mentioned, in some settings, you're deploying CNAs, PCAs, you're deploying health techs, you're deploying even student nurses to help on these teams. And these individuals are not licensed. And so it's important that team leaders know that these unlicensed assistive personnel, or UAPs as we call them, never take on an independent assignment. And what they're allowed to do in health systems is really dependent upon the policies of the health system and the training of the individual. And the team leaders need to be aware of what that training looks like, what those position descriptions include, and what you are and are not going to allow them to do. So I think you can very well see that to move into a team nursing model, the principles of delegation really need to be understood by team leaders. When you delegate, you really transfer a task to a competent individual. But, you know, the team leader in that situation still retains oversight of the care of the patient. You also want to point out to your staff that your registered nurses that there are certain things that they absolutely can't delegate to non-RNs, and one of them is the assessment or reassessment of patients. That's always within the purview of a registered nurse. Planning of care evaluation and decisions about whether to contact physicians about a change in a patient's condition. But there are many things that they can delegate. You can delegate activities of daily living, repositioning, and range of motion, which is, of course, really important when patients have been on ventilators for a long time. And then, you know, simple tasks around data collection, intake and output, weights, vital signs, glucose finger sticks, pulse oximetry, any number of things that they can, in fact, do. So the 5 rights of delegation for team leaders still apply. I mean, even though we're in an emergency situation, your team leaders really still need to be thinking about this. So the first is that you want to make sure that you are delegating the right task for that individual. Now, if you're fortunate enough to have a nurse anesthetist on your team, that nurse could assume responsibility for ventilator management, whereas a nurse deployed from a non-critical care area wouldn't have probably that level of experience unless she'd worked in critical care. The right circumstances, and that is really looking at the patients on the team, and you will want to consider information about their acuity. The patient's been in the intensive care unit for 5, 6, 7, or 8 days. That would be very different than a patient that had just been admitted within the past few hours. You also want to consider the right person. If you have behavioral health nurses on your team, you know, they could be instrumental in helping to provide both patient and family support. And then the right direction. Team leaders, and this is a challenge that team leaders face when they first usually take these leadership roles, is being very clear about what needs to be done, who's going to do it, and how we're going to check back to make sure that the loop has been closed on that. As an example, many COVID-19 patients are placed in the prone position during the shifts, and so deciding how will this be done and which members of the team are going to help in that function is important. And then the right supervision. For team leaders, they should never take the stance that no news is good news as an approach to follow-up. The follow-up needs to be planned and it needs to be frequent.